I'm Bob Challoner. I'm the President and CEO of Southampton Hospital, and I'd like to welcome you to the first event for our Tick-Borne Disease Resource Center that we're establishing here at Southampton Hospital. And I'd like to say just a couple of things. We're very excited about today's event and our two speakers, Dr. Luff and Dr. Dempsey, and I'll introduce them in just a moment. This Tick-Borne Resource Center is a new concept here in the South Fork. It's something that's really evolved out of community pressure, I would say. People coming to the hospital asking that we develop some sort of a program, resource, because of this epidemic of tick-borne diseases that we're experiencing. And all of us, I think, in this room who live, work, and play in the South Fork have probably pulled the tick off ourselves very recently. And many of us have dealt with tick-borne diseases, and it seems like every time you open up the paper, there's a new disease developing and new alarms, and lots of myths and lots of misinformation and lots of, frankly, hysteria out there. And our goal here at Southampton is to become a resource center for our South Fork communities, because we are being inundated with so many questions and concerns from our community members. There's a couple things that we want to be as a resource center, and there's a few things that we don't want to be as a resource center. And I would say that it's very much a work in progress. We are just beginning to put this together. And we're going to rely very heavily on the expertise, experience, and training of our medical staff, and make sure that this is guided by our clinicians. It's not something that we're going to look to outsiders all the time to do, although we will bring in outside resources and experts with help, but we very much want our South Fork medical staff to guide and direct this program. Some of them are here with us. I'd like to just introduce those that are here. Dr. Rajiv Fernando, who's in the back of the room. Dr. Halitsky from pediatrics. Let's see, stand up actually if you're on the panel. That way I can see where you are. Dr. Karras, Dr. Tony Knott, Dr. Aaron McGinty, anybody that I missed, and Dr. Dempsey, who's sitting up front here, and Dr. Jerry Simon, Mrs. Deborah Mala, who is our infectious disease nurse and will become a resource person for us as well. All of them have met several times, helped us plan this conference, and will be offering their expertise and help as we move this forward. And I have to say thank you to all of them. All we've given them is a couple of nice dinners. They're doing this on a voluntary basis. But I think the goal is really to use our indigenous expertise as much as possible, which certainly is great given the experience that everyone is having with tick-borne diseases. We plan on doing really three things initially with this resource center. And thing number one is to become a source of information, to gather as much information as possible, both for our medical staff and for the lay public. And many of the physicians and clinicians in our community are struggling with the conflicting information, and we hope that over time we can gather enough good information, make it available, create forums like this where clinicians can speak openly and honestly with each other and discuss outside of or secure from a public setting, and actually learn and educate themselves so that they can deal with what's going on in the community. So education is a major part of it. Education for the public will be part of it, and we're going to walk very carefully. There's a lot of controversy, as we'll talk about. We want to make sure that whatever we're presenting is evidence-based, and frankly that the information we give the public is good and reliable information. We want to become a place where people can turn for navigation and help. One of the questions we get asked frequently at the hospital is, I've been bitten by a tick, what do I do? I think I have a tick-borne rash, what do I do? My kid's been out in the backyard, do I need to dump chemicals all over my backyard? What do I do? So creating a navigation function for the public as well is another thing that we would like to do. And we will be relying on Debbie initially and hopefully growing that role. We've established a phone number. It's 726-TICK, 726-TICK, which I'm amazed we got that number. And we have a website, and we will offer the public the opportunity to call in, get help, and navigate them to appropriate resources. And some of you as clinicians have different types of expertise. Dr. McGinty has become quickly an expert in this meat allergy, and somebody that we can direct people to. And we will be looking to our medical staff, frankly, for those of you that want to be involved, so that we can get people to you and you can be a resource for the community. And then the third thing we're really going to be doing is looking for advocacy, planning, and ability to grow this center over time. And we've already met with a couple of donors. We've met with our local politicians. In fact, I'm meeting with Senator Laval tomorrow. There's been some money that's been set aside in the state budget. And we're going to look for resources and money to help grow and bring more resources, frankly, to the South Fork to make sure that people are treated appropriately. We do not envision becoming a treatment center. That's not our plan. We think we've got a lot of people in the community that already are providing treatment resources, and frankly, we think that those treatment resources are better placed in the offices and the doctor's offices that already exist out in the community. Nor do we envision ourselves becoming a research center. We're partnered with Stony Brook. We will continue to partner with Stony Brook, and we will be happy to provide a source where research material comes from out of our community, but it will be more in partnering with the larger facilities. We want to maintain our focus as a frontline community-based organization, and that's what our goal will be. We also are not going to become a political organization. There's lots of controversy, as you all know, and we don't believe that it's our role to be out there waving any banners or taking a stance. And we're going to try and walk a very neutral line. I'm sure that won't always be possible, but we do want to be careful on that. And we'll let the people that really want to get out there and advocate be the strong advocates. So that's really what our goals are. I'm very thankful to all of you for being here. We wanted to start with our medical community. That's the purpose of today's lecture. You are the front line. It's not the administrators. It's all of you who are the front line working with patients. And we wanted to give you the opportunity to understand what we're doing as an institution, ask us questions, and we also wanted to give you the opportunity to meet a couple of experts in the field and ask them any questions. And this is being taped. We're going to look at it and decide whether or not we edit it and put it on the CTV and use it on CTV, but we haven't made that decision yet. And one of my concerns is I want you as clinicians to have the freedom to ask whatever questions you want, without worrying about what goes public and what doesn't go public. In June, we're having a forum for the public where Dr. Fernando Jerry Simons will be speaking, and it'll be aimed at the lay public and will be something that will be televised and will be more of a helpful hints and facts for Lyme-borne diseases as we go into this season. But today is really for you and an opportunity for you to ask questions outside of the public forum. We also want to continue this. This is something that the community has asked us for. We want to make sure that it's a vital new center that's established. We're continuing to look for volunteers, any of the clinicians. Everybody that's here wasn't handpicked that's involved with our panel. They stepped forward. If any of the rest of you would like to step forward and be involved, please, we need all the help that we can. But we would like to continue this. So one of the things we'll ask for today or after this forum is for you to come up with additional ideas of the things that we could do at future panels, both for you and also for the public. And we've already batted around a few ideas. Some of them are, should we focus a session on kids? Should we focus a session, somebody suggested bring in a couple veterinarians and talk about what do I do with pets? Is that something the public may like? But there could be any number of topics that we would focus on. And we will also be creating, other than just the two symposia that we have planned this spring, we will be creating additional educational opportunities, posting things on the website. Our panel of doctors will be reviewing everything that gets posted or sent out to make sure that they agree with it, and we hope to have a real engaged debate about it. We'll also be doing CTV episodes and other things that we can do to educate the public, and advertising this advocacy or this navigation hotline, which Debbie will be calling. Have you received any calls yet? None. So get your patients calling 1726-TICK. We won't check their insurance either. We'll offer the advice free. It's rare you'll hear an administrator say that. So that's where we're going. That's what we'd like to create. Like I said, it's very much a work in progress, and it's an opportunity for our clinicians to really create a service for our community that we believe the community wants. Any questions or concerns before I introduce our speakers? Great. Well, thank you for being here. And let me just introduce our two speakers, and I'm very, very appreciative of both of them stepping up and being here with us. First one, Dr. Benjamin Luft is the Edmund Pellegrino Professor of Medicine at the Division of Infectious Diseases at Stony Brook. Dr. Luft was an undergraduate at SUNY Stony Brook in 1979, and he got his MD degree from Albert Einstein College of Medicine in 1976. Dr. Luft received his infectious disease training at Stanford University School of Medicine. He's been a member of the faculty at SUNY Stony Brook since 1984, rising to the rank of Edmund D. Pellegrino Professor of Medicine. From 1994 to 2006, he was chairman of the Department of Medicine and director of infectious diseases. Dr. Luft is a nationally and internationally renowned expert in the diagnosis and treatment of both toxoplasmosis and Lyme disease. He was instrumental in the development of ceftriaxone and a therapy for Lyme disease. I can say DRG, I can say accountable care, but I can't pronounce any of these medications. His research into the molecular biological structure of antigens of Borrelia species, which is known to cause Lyme disease throughout the world, is for the purpose of developing sensitive and specific diagnostic tests, as well as the development of a vaccine, which is now undergoing testing in Europe. And Dr. Luft, we thank you very much for being here with us. Dr. George Dempsey. You all know Dr. Dempsey, but he's been in private practice on the East End for the past 12 years, seeing patients at the East Hampton Family Medicine Center and also East Hampton Urgent Care. Dr. Dempsey was an undergraduate at the University of California at Los Angeles in 1985. He received his MD degree from Mayo Medical School in 1989 and his residency and a fellowship in family medicine at Stony Brook. Dr. Dempsey is board certified and a fellow of the American Academy of Family Physicians. In addition to maintaining a very active practice, Dr. Dempsey is working to identify the strains of Lyme bacteria contained within the ECM rash and observing its clinical outcomes. Dr. Dempsey is also actively participating with the San Francisco Bay Area Lyme Foundation and the Tick-Borne Disease Alliance, which is working to create a national Lyme biorepository. And I know that Dr. Dempsey will be talking about that in his remarks. I'd like to introduce first Dr. Benjamin Luft. Thank you.
Well, thank you. This is really a very exciting time to be here in Southampton with the formation of your new center. I think it's something that is really important, and I'm hoping that as it evolves, that its mission will continue to evolve and grow, and who knows, maybe you will come together and develop a virtual treatment center, because my belief is that there's so many people in the community that has such a great depth and breadth of knowledge, but each of us in the current era of medicine is specialized and subspecialized, and sometimes an organization like a hospital can form a virtual center. People in their practices but know how to interact with one another and then provide patients with the full compendium of care that they actually need, and which is usually sorely missing when you go and see an individual doctor. And that's part of what I'm going to talk about here, is really about Lyme disease as a multidimensional disease. So what is Lyme disease? Well, Lyme disease, we all know, is caused by the spirochete Borrelia burgdorferi. Its transmission is through the tick vector, the Ixodes tick, by and large. The animal host is for Ixodes is predominantly small mammals during its early part of its life cycle. And then during the latter part of its life cycle, in its adult phase, it's the deer. So, and where does the Lyme disease organism preside in the animal? Where does it reside? Well, it resides in the small mammals, by and large. So the actual place where the action is occurring between the tick and the acquisition of the infection is at the level of the small mammals, at the level of the the mouse, the squirrel, the small rodents. And the deer, which get a lot of play in our press, is really the place where the tick takes its last meal as an adult. And actually the tick provides the venue for where the sexual activity between the male and the female occur. And that's really what its most important role is really to provide that last meal, provide the venue. The female then takes its last meal and then lays its eggs, and then the life cycle continues. And this is a little schematic of the life cycle of the organism, of the tick. And it's important to understand this life cycle in order for us to understand all the problems that are associated with Lyme disease, how you acquire the disease, where the problems are, etc. As I said, this is a three-stage tick. There's the larval stage, there's the nymphal stage, and there's the adult stage. Being a three-stage tick, this tick is also called a three-meal tick, because it only takes 3 meals in its entire life cycle. It takes a meal as a larvae, as a nymph, and as adult. It's not a promiscuous feeder. It actually goes to one person or one host and takes its meal, drops off that host, and is satiated until it undergoes its next, molts and undergoes its next stage of its life cycle. So it's not like a mosquito, which goes from person to person, biting and spreading their disease. So what happens is that in the springtime, the larvae are formed, and the larvae then go off and become in the nymphal stage. In the nymphal stage, the eggs are formed. The larvae are then hatched. The larvae then feed on the small rodent, on the white-footed mouse, and it's during that phase about 50% of the larvae become infected with the organism. Then later on, it molts. It then infects the new crop of mice that are now being born. Those new crop of mice are then infected by the molted larvae, which has become a nymph, and then you have the life cycle that continues. So by and large, most of this infectious process is occurring within nature. It's not occurring, we are incidental to the life cycle of this organism. It's only that during the nymphal stage of the tick, if there isn't a small rodent readily available, a small mouse or a small squirrel, and if a human walks by, that nymph will say, you know what, my choice cut is a mouse, but I'll take the human. And then they'll go over and bite the human. Now it's important to understand that these ticks are not flying around in nature. Basically, they have a very well-defined habitat. They usually are sitting on blades of grass, usually closer to the top of that blade of grass. And when you walk along and you brush against them, they'll basically come onto you. It's not that they hop over to you or something of that sort. You actually have to come into you have to come close to the tick in order for it to make its way to you. And what it does when it comes onto you is it tends to start to crawl up your leg or wherever it comes up to, and it likes to bite in certain places. And I think this is just one of the take-home messages. It likes to bite in places that are warm, and it also likes to bite in places that are wet. So most of the time when you see these tick bites, it's behind the knee, it's in the groin, it's around the hairline, it's in the neck, it's in these area of creases. And it's important to realize that because when, the thing that we always tell people about being able to prevent Lyme disease is to do a tick check. Those are the places that you have to do the tick check in particular. And that's especially for children, around the ears, around the hairline, because that's where the tick will be lodging and taking its blood meal. It could take a blood meal on your body, but by and large you have to kind of look in those areas in between. Now when the tick takes its blood meal, it does so for about 48 to 72 hours, 48 to 96 hours. But it's only during the latter part of the blood meal that the Lyme disease organism is actually transmitted. So in order for the organism to be transmitted is that the tick has to be on your body for about 48 hours. And that's very important also because if someone is very fastidious and looking at their, at their bodies or their mates' bodies or their children's bodies and doing, the tick checks, if you do that every day, the likelihood of being able to find the tick and being able to prevent the infection is very high, right? Because you do it within 24 hours instead of 48 to 96 hours. So it's an important practical point. So we all know the early manifestations of Lyme disease. The erythema migrans rash occurs at about somewhere between 50 to 75% of the time. But that's very important because many patients may not have the erythema migrans. It's not a good picture, but I think you've all seen it. But the important thing is that the pathognomonic rash does not occur in 25 to 50% of the time. And during this period of time when these tick bites are occurring, the patients can be presenting to your office with just a flu-like illness or just not feeling well. So you have to have a very high index of suspicion that someone may have Lyme disease. And this is further complicated, I think, as George will tell you, will remark, is about with the diagnostic test. Because if I'm saying that the pathognomonic side is not present in 25 to 50% of the time, then how are you diagnosing Lyme disease? And you're basically, maybe you're relying on your clinical judgment or you're relying on serological testing, which may be wanting. Then there are the chronic or untreated manifestations of Lyme disease. Lyme disease is one of those organisms, and I think it's another key point that people just don't realize. The reason why you treat Lyme disease early is not to get rid of the rash. The rash will go away on its own. The reason why you have to treat Lyme disease early is to prevent the late manifestations of the disease. It's preventive therapy. The early manifestations of the disease is usually innocuous. It's like a flu-like illness, few days, it goes away. A rash that is not painful or bothersome is there, it looks a little peculiar, but it goes away. But the problem is that this organism has the capacity to go into hibernation into your body, only to recrudesce later on in life, giving rise to a variety of symptoms and signs, including arthritis, neurologic disease, neurocognitive problems, skin disease, heart disease, a wide variety of diseases. And that's a key point. Early treatment prevents the late manifestations of the disease. For all the problem cases that you have in your office, which are usually these late manifestations, they all could have been prevented if the patient had been treated early and adequately, almost uniformly. So the problem with Lyme disease is it's like the metaphor of the elephant. You have a lot of different specialists. You have a lot of, I think we heard all the different types of people that are involved in it. You have ecologists, and you have animal rights people, and you have, advocates, and you have doctors, and you have nurses, and you have psychiatrists, and you have psychologists, and you have social workers. They're each looking at this disease in their own, as in the old adage of the blind man trying to describe the elephant. Each one of them describing a different aspect. The problem with in our medical community, in my opinion, is that we've become so segmented and fragmented that each of us doesn't understand what the other person is actually saying. And I have, I can tell you, offline I'll tell you about my experience. I run the World Trade Center Health Program. And it's a very integrated type of program as far as looking at specialties. And it's only by doing that in an integrated manner that you actually start to understand what the disease is really all about. So Lyme disease is really a continuously emerging and diverging disease. It's the most frequent vector-borne disease in the United States. It's transmitted to vertebrae by the Ixodes tick. It begins in the skin and may spread and may disseminate other organs. It can basically hibernate, giving rise to disease later on in those organisms. If diagnosed and treated early, it is cured in the vast majority of patients. And that has to be the mantra. How do we treat Lyme disease early? The treatment for Lyme disease early is very easy. It's not very toxic. It's not going to have an impact on antimicrobial resistance. This is the type of nonsense that you hear. But it will prevent the late manifestations of the disease. If left untreated, severe disease can occur, such as arthritis, CNS, and cardiovascular disease. This will occur in the majority of patients that are left untreated. In a relatively small percentage of patients whose therapy was either delayed or inadequate, chronic disease, most often manifesting as neurocognitive, rheumatologic, somatic complaints, etc., can occur. And that's important also. Whoever says for any infectious disease that any therapy is 100% effective did not train in infectious disease. That is total nonsense. I don't know any study of any infectious disease which is 100% effective. And I think as a, I just find it so difficult how often practitioners are coming to me afraid to retreat because they said, I treated once. I said, well, okay, first of all, did the patient have Lyme disease? Okay, that's usually the biggest hurdle. Did they actually get infected? And then we go in and we do a lot of hand-wringing about that. But there is no infectious disease, even a strep throat, that is where you give therapy that is 100% effective, let alone pneumonias or serious systemic diseases. So I think it's important to remember that. I'm not an advocate for long-term therapy because it doesn't work. And that's what's been shown. But I do think that anyone who says the opposite, that it's totally effective, is absolutely wrong. So, and this is an important slide, and I'm glad I put this in because I have a limited amount of time. I don't want to take away from George. This is very important, especially for what you're doing. And I think it's something that you should kind of remember. This is a slide that I got, that I took from a talk I gave at the Institute of Medicine, which was charged to come up with a report for Congress. That in order to understand Lyme disease, that you need a multidimensional approach. Not only a multidimensional approach, but a multi-professional approach. And that's why I'm so excited about the hospital doing this, putting together these people who are smart, sophisticated, and have a broad knowledge. You have to identify the various biological, neurological, psychological, economical, and sociological aspects that ultimately affect the severity of symptoms, response to treatment, to chronicity of disease, and overall disability of patients with Lyme disease. Now, whatever Lyme disease is, you have to do that. As a practitioner, a patient says, Lyme disease, they say, you don't have Lyme disease. The next thing that usually a patient asks, well, what do I have? What do I do? How do I get taken care of? And that's where the quandary comes in as you guys, as practitioners. I live in the luxury of being an academician. You know, it's such a luxury. I say, well, I'm studying it. You have to deal with it. Very hard. And I have the utmost respect for that. You have to develop the biological clinical instrument to quantify the disorder, to develop a universally accepted phenotype of the disease. No subspecialty has developed a conceptual or therapeutic model of dealing with this complex disorder or with other infectious or post-infectious disorders. And I think that that's a really an important thing, is that there is no subspecialty. My subspecialty doesn't have it, psychiatrists don't have it, rheumatologists don't have it, but all of us together, social workers, psychiatrists, psychologists, all of us have just a piece. We're all blind men trying to deal with the elephant. And it's important, if you could embrace that, we'll be a hell of a lot further along on this journey of trying to help our patients. Few medical centers or any centers of excellence are equipped to deal with the full compendium of medical, psychological, and social implications. I think at Stanford they're starting to do this, Stanford in California. And the ramifications of this is that third-party payers are not responsive to the needs of the population, and there are a few practitioners who have been specifically trained to deal with this disease. Third-party payers, you know, they love it when there's a lot of confusion within the community. They just say, well, you're confused, you each say it, we're not going to do it. You know, we don't have to do it anymore. It's important. So I'm going to talk very briefly a little bit about what we've done. I've taken a very biological approach. Well, you know, I saw patients, I see patients. Like was mentioned, we developed most of the current therapeutics for Lyme disease. You know, ceftriaxone, we did some of the pivotals. We did the pivotal studies. We discovered its utility. Doxycycline, amoxicillin, how it was optimally used. But biologically, I've been very interested in looking at the antigenic structure of the organism. We solved the structures with our collaborators at Brookhaven National Laboratory at an atomic level. We mapped the epitopes and we engineered a unique vaccine. We've sequenced about 22 different genotypes of Borrelia. So we now have a map or knowledge of every protein that this organism is able to produce. We know we know every variation of every protein that it can produce. Now this has been extremely strong for us in the development of diagnostic tests, and I'll allude to that at the end. We've been able to look at different studies as to what the proteins the organism produces, whether it's in the tick or in the body, but even more importantly, when you culture it in the test tube. Because that was the greatest limitation for our diagnostic tests today. Because the organism, when you culture it, only produces certain proteins and not other proteins, which are important in infection. And we've developed a protein microarray for the sensitive and specific diagnosis, and I'll talk about that. First, I'll talk a little bit about one of the thing that I've been most proud of, maybe not most proud of, but certainly proud of, and that has been the development of a vaccine for Lyme disease. I mentioned that we solved the atomic structure of this is the major outer surface protein of the organism, which was the OspA protein. As you may know, the organism is very diverse when you go from the United States to Europe or Asia. There are basically multiple genotypes of the organism, multiple species. And so we wanted to develop a vaccine that was universally effective against all strains of Lyme disease. We solved its structure. We identified the protective epitope, which is labeled as LA2, and that included 3 loops, A1, A2, and A3. And what we did was we bioengineered this protein. And this is just a little cartoon. We took pieces of the protein from different species of Borrelia that cause Lyme disease, and we made a chimeric vaccine. And what we showed was that when we looked at these chimeric vaccines, that the activity of those vaccines were much greater than the parent vaccines. that the whole was greater than the sum of its parts. And so we tested it, and this is just, as was mentioned, Baxter is doing human trials. They just finished their phase 2. But this is some of the work that we did with in mice, just to give you an idea. And you can see the antibody levels that we developed. And even more importantly, when you looked at the vaccine, these are the various vaccine candidates, and you looked at Borrelia that was either isolated in the laboratory or in Europe, and these are the North American type strains, that the vaccine was highly effective in the treatment of Lyme disease. You can see we had between 74 and 90% efficacy in our controls. Virtually all of them became infected. So here we have a vaccine that was active against both the human strains, about the European strains, as well as the North American strains, and I think this it really offers the promise of a universal vaccine against Borrelia. Now, one of the other things that we were very interested in, and I think this is very important, is that we wanted to see, as I said, one of the major things that was important was looking at the diversity of the organism. How variable is the organism in your environment? And what does that mean clinically? And so we did a study where we looked at the Lyme disease organism in the ticks, in the skin, and the invasive isolates. And when we looked at that, we were able to, because we had a lot of knowledge as to the genotypic differences, or how these strains varied from one another. And what we were able to show that within the tick, we were able to find about 22 different genotypes of Borrelia within the tick. That if you look at the family tree of the tick, of the Borrelia, that there would be 22 branches. But when we looked at the skin, we only found that 10 of those 22 that actually caused the erythema migrans. And when we looked at the organism even further and looking in the blood, we only found that there were 4 predominant strains that caused invasion in the blood. And what this means is that although we talk about how much Lyme disease is out there, what may be important, or even more important, is what is the strain of the Lyme disease? What is the type of the Borrelia that's out in your community? And maybe that what you see is that it's not just a matter of whether the organism is there, but really what is the balance of organisms that might be there. If you have a lot of these around in your ticks, you're going to get a lot more invasive disease. If you get a lot of ones that are just tick specific, then you might not have any disease as well, even though the Borrelia will be there. So we kind of have to know that type of thing. And my prejudice is that the spread of Lyme disease is not necessarily due to the spread of the organism, but of the spread of specific isolates becoming more predominant in a particular environment. And that's very important for us to understand, because when we start to think about strategies as to how we may want to attack it, it may be just a rebalancing act that's needed, and not necessarily the eradication of all of the reservoirs. Let's get rid of all the mice, let's get rid of all the deer. That might not be possible, but maybe rebalancing is much easier to do. Just something to think about. So as I said, there are 3 species in Europe and the US, and that's how we developed our vaccine. But I wanted to talk a little bit about these genotypes in our own environment. And this was a study that I did with Mark Eshu, who's at Abbott, is a big collaborator of George's as well. And what we looked at was looking at the different genotypes. Oops. I talked about the genotypes in New York, Connecticut, California, and Indiana. How do these organisms vary? And just look at the pinwheel here, the different colors. Each of those colors represent a different genotype. And what you can see is that even between New York and Connecticut, that they're not the same. Right? Just the sound, that's all it's, Long Island, Connecticut. Indiana is different, California is different. So when you have different variations or different combinations of organisms that are out there, It may be very different in terms of what your disease manifestations are. Maybe certain strains cause certain types of disease. Maybe one causes arthritis, another one causes neurologic disease. Maybe some are more susceptible to antibiotics, maybe some are less susceptible to antibiotics. All sorts of differences. And you have to start to understand that in order to understand what the limitations are of our knowledge. And that's very important. You know, to kind of be a little bit humbled is not a bad thing, especially when you're dealing with medicine. And here's an example of I just wanted to look at the differences between Connecticut and New York, just to kind of see how varied that is, to give you an idea, because it's close to us. You know, it's not like New York and California. This is just across the Sound. Here you see that we looked at 105 ticks in New York, 61 in Connecticut. There were 15 genotypes that were common, but there were 16 genotypes that were only found in the New York ticks and 4 that were only found in the Connecticut ticks. Again, variation. So New York and Connecticut have many shared genotypes. However, there are some that are unique. This is the number of genotypes that are in a particular tick. You know, you think about the tick, you say, well, it got bitten, you know, by a tick. You think, well, you got bitten, but you have one organism. You know, it's usually, that's how we usually think about things in infectious disease. But even within the Borrelia, within those ticks, there can be multiple genotypes. And you can see that in 39% of ticks, there were multiple genotypes of Borrelia. That there wasn't just one strain that you were getting infected, you were going to be infected with multiple strains. And what's the importance of that? We're still trying to figure that out, but potentially the immune system is fighting 2 different infections simultaneously. How does that affect the disease? So you're seeing all the variability from person to person and how they're presenting with disease. The 2 genotypes may have synergistic effects. We don't even talk about that. If you get infected with 2 organisms, one may kind of cripple your immune system, the other one might cause invasion. It's all, we know that these things are occurring in the animal model. Why isn't it occurring in humans? And then to make life a lot more complicated for all of you, I just want to make it as so that, you know, you cut over and you say, oh my God, you know, I'm glad that, you know, that you have Luft, you know, sitting in a lab, you know, doing this type of stuff. He has some utility, you know. You have to start looking about, so we have all these complex, you know, the Borrelia is very complex in the tick. Now what is it? What about all the other types of organisms that were mentioned? And so here we looked at the tick, 299 adult Ixodes ticks from New York and Connecticut. Many of them, you know, probably George gathered a good number of them, you know, in his backyard or whatever, kind of with his blanket, you know, trawling about, you know. And we analyzed them for a variety of other organisms, as well. And I think, again, you see the complexity that is there. You see, well, in this of 299, 138 only had Borrelia burgdorferi. Of course, they had a variety of different Borrelia burgdorferi there, but we won't go into that. But all of these others, whoops, these ticks contained a multiplicity of different organisms in different combinations. They contained Babesia and Anaplasma and Powassan virus, you know, and so each of these occurred in different combinations. And so when people become infected with a tick, you know, bitten by a tick, you don't only have to consider Lyme disease, you also have to consider these other infectious diseases as well. And so this gives you an idea of the complexity and the difficulty that you're all facing. Okay? How much? You tell me when I stop, Joy. I'll finish in a minute. Okay. All right. So that's, and I mentioned this already. I just want to mention a little bit about what we've done in terms of our sequencing, because I think I want to talk at the end about a new diagnostic test for Lyme disease, which maybe we can work together with. So this is the family tree of Lyme. This is you can see how complex it is. And what we said is, look, this diagnostic test, which George will talk about, it's just too difficult. I mean, it's too difficult. It doesn't help you. It's not positive often enough. It's not diagnostic often enough. It doesn't have the specificity. It doesn't have the sensitivity. And everybody's looking for their favorite protein. So, I'm a kind of a guy who's like, I'm a kind of a techie. I like the newest thing. And I said, you know what? This is silly what we're doing. I'm not going to search around for a particular gene. I'm going to know all the genes. I want to sequence the entire organism. Not only do I want to sequence the entire organism, but I want to sequence every variation of the organism. And I'm going to know what the entire family portrait is of all the genes that these organisms can produce. And so what we did is we took the organisms, we divided them up, and then what we did was we said, okay, this is the family tree, and we want every variation. That we went all over the world, and we found that there were 22 different organisms that represented each of the branches of the family tree of Borrelia. And we sequenced the entire organism. That means that we sequenced, and we knew about 1,500 proteins for each of those different variants. And I just wanted to tell you what we did. As we began to sequence more and more genomes, this is up to 14. These were the number of new genes that we were finding as we sequenced more and more organisms. So, one organism, there would be, you sequence the difference between one organism A and organism B, genotype A and B, you might find that they're 90% or 95% identical. And so you kind of put that into your bank. So we went up to 14. We've now gone up to 22, and it's just the number of new proteins that we're now identifying has come down to maybe 1 or 2 new proteins every time we sequence. So we stopped sequencing the genomes. But by doing this, it provided us a fantastic new tool. We now have every protein that this organism is able to produce. We're able to go back into our databases and identify what are the proteins that are unique only to Borrelia burgdorferi, that don't occur in any other organism. Then we're able to go by and say, of all of those proteins, which of those proteins are actually immunogenic? Which ones actually cause a reaction that may be important for diagnosis? And by doing that, we then was able to come up with a very small number of proteins, well, relatively small number of proteins that we began working with, which is about 300 or so, but it's much less than 30,000. And we were able to come up with those proteins, and we were able to say, can we diagnose Lyme disease universally? Can we say any person who comes into your office, can we say definitively, and now this is not to do with cost and this and that, I'm not, because I'm an academician. I don't think about those things, cost or, that's a hospital, CEO, he's worried about that. I'm just thinking about but I just wanted to get to that point. And so we were able to go ahead and be able to say with almost very close to 100% certainty, I could say that this person has been exposed or been infected with Lyme disease or not. And I guess that's the great hurdle that we've just recently overcame that hurdle, and we're able to do that, and gotten down now to, by various bioengineering and manipulations, to the point that we now have a relatively small number of proteins, only 11, that can do that. They're not found in nature. They're engineered type of proteins that are polypeptides, et cetera. But I think maybe at the end I'll have a chance to present a little bit of that. But I want to give George the floor because he has a lot of important things to say, and he's actually seen the cases.
Okay. Okay, well, as a community physician, you all know the difficulties and frustration we have with interpreting Lyme testing. And so I've been devoting a lot of time reading about it and trying to get a handle on it. I think we all know what it's like when you have a patient comes in who say have chronic Lyme and their tests are all negative. And you have another patient comes in, their Lyme test is completely positive everywhere, and they say, well, I feel fine. Why do I need to be treated? And then everything in between, where you have other colleagues, patients coming from someone who told them that I have a 41 kilodalton band, and therefore everybody has Lyme if they have that one band, even though the CDC says it has to be 5. So I got very frustrated, and I've gone through a lot of reading, and I just want to go through what we do know, review it again with you, and review how the testing's done and what makes it work and what makes it doesn't work. And I'll just try and go through these fairly quickly since we're already experts on this. If I can figure out how to do this. There we go. The first slide will be the busiest, but it also is to demonstrate how complex it is to understand the testing we use, the serology we use. And based on, oops, here we go. That goes negative. Across the top, you'll see 4 rows of different types of tests. And as you go down, you have patients with Lyme with a rash, without any signs of illness, then people with the rash feeling ill. Then you have stage 2, where people are beginning to have neurological or other symptoms, cardiac symptoms. And then stage 3, the persistent disease, where they're having more chronic neurological difficulties and with arthritis. And at the bottom is healthy subjects in areas showing how well these tests work in someone who's healthy, who doesn't have disease, your false positive rates, and so forth. Well, as you can see, it's fairly complex. And I would just want to focus just a little bit on it, is that in the beginning, if you look at the acute phase, you can see that early on, acute is usually within a week or 2 of becoming ill. If you look at the percentages in parentheses there with all of these tests, they're quite low. You see 19, 11, 6, 17. The last one on the right is the ELISA with the Western blot, including IgM plus IgG. So it's really almost a summation of the first 2. But in early stage, you're just not going to pick it up with someone with a rash. The second part, which is the migrans with disseminated disease, which means you have the rash, but you're starting to feel ill, the numbers start to jump up. If you're developing an immune response, then these tests start to pick things up there. You see 38%. The IgG is lower, 15, and then you put it together, you get 43%. And that's basically a normal immune response, though, with any kind of disease we have, if you're trying to use serology. It's not something that's unique or mysterious about Lyme disease, that any infection you have will take time to begin to develop these antibodies. And I'll go from there. First of all, in serology, we're dealing with property of protein, and they're nice and sticky, just like our eggs on our plate. And as the eggs get cold, the eggs get sticky, and it's hard to get off your plate. And that has a lot to do with, if you think about when someone's doing an assay in a laboratory, how they're managing the stickiness. We have different types of antibodies, which I'll go into. They have different levels of specificity and accuracy. And what you're getting is, you're not showing how active your immune system is. I mean, you're not showing the disease, you're just getting like a snapshot. At this point in time, we have this many of this. You're basically bean counting out this many IgMs, this many IgGs, this many IgAs. And it's not really proving that the disease is active, it's just saying what your immune system is producing at that point in time. It doesn't, as we know, doesn't show your infection very well. And you can't even use it as a test of cure. So after you treat someone, those antibodies are going to be lingering, and you really don't know whether your treatment helped. So antibodies in our immune response. Our initial immune response The innate immune response occurs within a matter of hours, and within the first couple days, we're fighting, but we don't know what we're fighting. We haven't developed a sophistication in our immune system. It's only when we have the adaptive immune response where we develop our antibodies that are becoming trained and honed to be able to know what they're fighting. And the adaptive immune response, you have your antibodies, IgA, IgM, IgG, and IgE. Just one point I'd like to make right now is you can see that IgM we do know is the early response. But if you look at it, if you remember now how different that is from the other ones, what it has instead of 2 valencies, 2 areas of binding, it has 10. And it's actually part of what we call the innate response as well. It's so early, it's not necessarily as specific, but what it can do is it can bind complement 400 times more than the other IgGs, which means when something comes along foreign there, it can glom onto it and have an early initial reaction of attacking a cell. And I'll get into that more later too. Now with what we do with our ELISA test, just to review, we get antibodies from a standardized strain. It's been the B31 strain since the early 90s, which is one of the most pathogenic strains we use. And just grind it all up, and then you put it out on a plate. It's sticky, so that the proteins stick to the plate. And then what we begin to do is we put the patient's serum over there, and if they have antibodies that recognize this antigen, these proteins from this sonicated cells that have been cultured, then when that binds and you wash it out, they'll stay there. Then you get another antibody to those antibodies. So we're creating an antibody against human antibodies from another organism, like another mammal, like a mouse or a rat. Those second antibodies have a chemical on them attached. You add a colorimetric assay after rinsing, and it turns color. So it's basically looking at a color. So after this whole process, you're looking at a color difference. And this is how it's measured optically, and how our labs report these results is a color type of assay. That's how accurate it is. The antibody capture technique is separating out the different types of classes of antibodies. And what this allows us to do is begin to separate out the early rise in the IgM from the IgG, which takes more time, and it helps us differentiate. And this is very helpful for us to at least get a sense of where the immune system is when we are looking at this patient. So here's the variability we have to deal with. You have different labs. Each they're using different preparations. They're buying kits. They're buying preparations from other suppliers. Each are going to have different cutoff values. So there's just no way you can compare one lab to the other. If you do a test at one lab and you do a test at another, you're going to have different numbers, different results, and you can't compare them or say that there's meaning between the two. So the strain that they're using, the antigen, but some labs don't even necessarily may not use the B31 strain, so you can't compare that. The anti-human antibodies, where do they come from? They buy it from somewhere. Where's the variability in that as well? The reagents they use, the protocols, how much time do they spend at a certain temperature that they're incubating these things for? That will produce a different result on your test as well. What about the technicians on that given day who are working that day? How closely are they following the protocol, and so on and so forth? So the Western blot, again, uses the same technique in terms of breaking up the cultured cells. You lyse these proteins. This time you put them across an electrophoresis gel. By charge and by molecular weight, they're going to layer out. And similar to the ELISA, then you apply the serum, you rinse it, you add a different type of labeled antibody, so you actually look at these. And this is what you get. These are 40 different positive Lyme tests there, 20 across on each side. And as you can see, the difference between them is quite remarkable. In fact, there's no two that are the same. So it shows that our immune response is uniquely different, as well as whatever we're being infected with, that there could be different, of course, types of organisms, different strains of Lyme that we don't even know how that plays out yet. We don't know how to read a Western blot that way. This is read by individuals. The mechanical, optical ways that have been done with this are not quite that well developed that we can rely on that as well. So you have an individual reading this as well. And you can see there's some consistencies between them, and then there's a lot of inconsistencies. So you have to piece it together. So a Western blot is not going to be one thing, one band that's going to tell you you have a disease. So I like to present it like you're looking at a dinosaur. And you might find a big femur in there and say, aha, I have Tyrannosaurus rex's femur here. But if you don't have the other pieces, you could be coming back to your university saying, I got Tyrannosaurus rex, and they say, no, that's a cow femur. And that's why you can't use one band or one combination of two bands to be able to put it. You got to get enough pieces together. And that's why the CDC came up with these criteria, which are based basically, if you want to look at it, statistical. If you get up to a certain number on each of these types of isotype antibodies, then you're going to get a high enough level of probability. Could you say 4 out of 10 bands IgG could be positive? Well, it could be, but it's going to be an outlier. And that's how we have to interpret these tests. We have to look at the whole picture, at the patient and the context of what's going on as well. But you need something you have to grab onto. So we have to take faith in at least some of the guidelines that we've been given. A Western blot takes time to develop. And an individual, as I said before, can vary in how they read it. And you have different kits between labs, so there's a lot of variability. What I'd like to do here is give you some examples of what we know about the natural immune response to Lyme in studies that have been done before we knew it was Lyme. These are from the 1970s when the serum was collected, but they weren't treating because they didn't know what it was. So what they found in the very beginning is these are 10 patients. They were not treated, and this is over the course of almost a year, year and a half. What you can see is that in the beginning, the IgGM was high, and this is 1 week into illness. But after the initial infection goes, the IgM just gradually settles down during active infection. So it is the early response, but it doesn't continue to fight. It just kind of drifts off in there, as well as the IgA and the IgE. Now the IgG steadily goes up and mounts and mounts and mounts and mounts and mounts and keeps going up. And this is over a year. That part of the immune system, the IgG part of the immune system, is a very active, evolving system that just continues and continues to fight the war. So there's a big difference between IgM and IgG, and that's the main point I want to make, because when we look at these things, I don't think we distinguish very well between the types of antibodies we're looking at and what they mean. Just a little note to the side here, this initial 1 week period here or so, Imogen Lab, who we are using, has developed a PCR. And be aware now that they have a PCR that they've enhanced and they feel they have better sensitivity, that they can get it over 50% in the first week. If someone's ill, feverish, and not feeling well, they have added that to their panel. And that may be worth doing. If you pick it up, you probably have it. So that's a little addition to what our armatorium, what we have now. Now, one thing to note is that once you get up to arthritis stage, which is months later, everyone's pretty much positive in their serology. I mean, it does work. It's just early on, it's notorious. And also at the IgM, that overreacts there, that basically IgM does persist. Now, this is someone who was treated, and it was after a week. They waited a week and then started treatment. So they already had the elevated IgM, and then it just kind of lingers. And after a week of treatment, the IgG still shot up, but then gradually settled down after treatment. Just to give a sense of what the natural course of what these things are. But the main thing too is to realize IgM sticks around, and we get IgMs a lot in our testing, and a lot of people struggle over what that means. This is someone who was treated at the very beginning, and at that point the IgG never really developed. It didn't get even a chance at that point. But the IgM did rise after treatment for a period of a few weeks. This is about a month, and then it kind of drops down, and it keeps persisting, and it can even go for many years. Here's side-by-side Western blot and antibody capture untreated. So this is the natural course of this disease. In the first 5 days, you're not going to see much on the Western blot. You have something here. And by 3 weeks or 4 weeks, it begins to show some bands showing up there. By a month, now you're starting to show, and that pretty much fits what we've been saying, that you got to wait 4 or 5 weeks for this Western blot to begin to show something. But then notice that over time, over a year, almost a year and a half, it continues to evolve. And I find that very interesting about the IgG, to be aware of that. The IgM here rises in the first month and then just drifts off. IgA is also in our antibody capture and the testing most of us get, and that rises and then drops off. And then here's the IgG, just steadily rising, steadily rising, steadily. It doesn't quit. It's an ongoing rising immune response, inflammation over time. And that's the inflammatory part, probably, of what we're dealing with people with chronic infection. So back to the IgM, because I think I want to make that the main focus of how we interpret our testing. And my main point is it has cross-reactivity. And we know, most of us know these. Syphilis, if you have gum infections and irritation, you can get spirochetes in your gums and that sort of thing can set it off. Rheumatic hepatitis, Epstein-Barr, and probably other things where someone's ill, they have a generalized illness, they're more likely to have a positive IgM. And we have to take into account when we look at the patient. It's not just the test, it's the patient as well. The dilemma we have here is that we get someone who has a low IgM and everything else is negative, right? We get that a lot. And the concern is, it could be cross-reactive, could be a new infection in the beginning, or it could just be that leftover IgM we're going. We don't know. We get one point in time with this test result. So the main thing we're concerned about is whether we're going to have a new infection. The advantage we have with the lab we do use here with Imugen is it's the only lab we know of in the country that actually freezes your serum, and you can repeat it later. So you have consistency of the same technician, the same antibodies. Everything's preserved and the same samples run over again. So at least you can do some comparison over time. You can't do that with any of our other laboratories, but we should take advantage of that. So what does that mean? We have somebody, we're wondering if they have a Lyme infection, they have an elevated IgM. Repeat it 2 weeks later. If they have an active infection, that IgM is going to really rise. It's not going to be like 2 or 1.6 or 1.2.8. It's going to shoot up over a 1 or 2 week period. The IgG may or may not respond. Sometimes we see that go up. And same thing with the IgA. And meanwhile, the Western blots are not likely to happen. But our concern is that early period of time, that 2 or 3 week period that someone's been ill, that we just can't rely confidently on our testing. This at least is a little bit of a tool, a suggestion of what you can do to give you a hint that, hey, yeah, this is really an active infection. So I just want to throw out a couple fun little cases, and if people want to jump in, we can jump in. Basically, we have a healthy 42-year-old person comes here for their physical in November. It's after the season. They feel fine. There are a lot of ticks around, never got bitten, but I just want to be checked. I like to get checked every year for Lyme disease. So they say, okay, you run a test, and sure enough, what does he get? He gets an IgM of 1.6, and everything else is negative. What do we do? With a smaller group, we could have a discussion about it, but what are your options? Well, just treat them. Well, you could have Lyme disease. I'm going to treat you for 3 weeks. Or 2, tell them, this is a false positive. You're healthy, you're otherwise healthy all your life. It's not an issue. All you can do is you can repeat in 2 weeks, and if it's not changed, no IgG develops, or IgM doesn't rise, then you can feel confident it's not an active infection. Or 4, you can order a Western blot. Now these are all options. I guess at this point in time, there's no right or wrong answer. But I would lean pretty sure if he's healthy, it's going to be a false positive. But I could repeat in a couple of weeks. If he's really been acquired a disease from last summer, you should be able to show something in a Western blot by now, if it's been ongoing that long. But perhaps repeat in a couple of weeks, and that'd be reassuring to the patient. Another one is a female. Common thing we get is someone comes in with summer rash, and not without a rash, but they're sick, and we test them. They got positive for Babesia, and they got positive IgM for Lyme as well. So now we got to deal with two infections. So we got to treat them with a bunch of antibiotics. We give them Metron, Githromax, doxycycline, and we say, come back within the week. She calls a few days later saying, I'm better, but I can't tolerate the doxycycline. I'm throwing up like crazy. And she also, this medicines are expensive. I can't afford to buy all these medicines. I'm already feeling better. Can I just take what I'm taking? So you got an option. You could stop the doxycycline or repeat it in a week, or you could just say, you know what, we're going to switch you to amoxicillin. It's well tolerated, and you'll do fine for the next 21 days and call it a day. I guess what I would tend to do would be I would tend to stop it because it's early. You could always restart it, and in a week or so, if the IgM starts to shoot up, then you know that, hey, this really is a Lyme co-infection. You can retreat it. You can go either way. Now, the other point is that say you stop it, you repeat it in a week, nothing changes. The IgM stays the same, nothing changes. Was this because the antibiotic stopped the immune response? Well, not exactly. It will still go up, even if you start treatment. You still have, the immune system doesn't just stop in its track. It's a train that started moving. So you will have your IgM start to rise after that. So if it hasn't stopped, then it's not a new infection. So that's what most likely is what it is. And the Western blot, at this point, it's not going to help confirm anything at this stage. So that's my cases. I hope that's given a little bit of tools to think about and work with this summer. Let's see here.
Okay, so I just want to finish up here with what the future is. I think that, as George showed, the serological testing for Lyme disease during the early phase, you have, when the patient first comes into your office, that a minority of patients will have a positive serology. And later on, when the patient comes in with their convalescent sera, probably around 25 to 30% will have a negative serology. So as a clinician, what you're always going to be confronted with is uncertainty. When you do the serological test, the likelihood with very early disease is the likelihood is that they're going to have a negative serology. And when you're going to look at that convalescent serum, the likelihood is that a significant minority will have a negative test. And so you go, what do I do? And a lot of it has to do with the fact that these tests have really lacked both sensitivity and specificity. The ELISAs tend to be a little bit more sensitive, but just very nonspecific, and the Western blots have their problems as well in terms of both sensitivity as well, and you have to use a high accumulation of antigens in order to get the high probability, and that's a big problem, because there are a lot of people, as he showed in his slides, will be negative with that. So as I said, what our approach has been to really profile the entire humoral response against every known antigen that the Lyme disease organism has. And so we do this by looking at these things called arrays. We spot on our slides, when we began, we spotted about 700 proteins. Then we went down to about 350 important antigens, and we look at what the antibody response is. And what we found was that different people have certain antigens that they all respond to, or that not that they all respond to, but that a significant percentage respond to, and certain antigens that are very idiosyncratic from one patient to the next. So we had about 165 antigens that 50% of patients would respond to who had erythema migrans, and then there were about 50 other antigens that some people responded to and others did not. And you can see this is an example of where there is, antigens that are specific to an individual and antigens that are common. And this is what we do. These are heat maps that kind of show you the different Borrelia proteins, and these are different patients along the side. And you can see the differences in response. Red is a positive response, green is a negative response. But by doing that and being able to start looking at this with using these microarrays, and this is looking at about, as I said, a very large number of proteins. We got some sera from the CDC, 15 sera that they use. These are patients who just come into the doctor's office with erythema migrans. And you can see that in this series, 54% of them had a positive Western blot and ELISA. And 100% of them, we were able to identify that they had Lyme-specific antibodies. And so this really provided us with the basis that there is a way to be able to look for this early antibody response. It's just that you can't look at it very narrowly. You have to be able to do it in a much more broader way. So what we began to do, because we had so many different antigens, and I don't have slides on this, but I can tell you, just to give you a little summary, is that we began to take these different proteins that we had, and we began to build new proteins, polyproteins, where we kind of hook them up into kind of a little bit of into a chain. And we've gotten down now to about 11 proteins that contain many other proteins within them, which really are able to identify virtually everybody who has Lyme disease. And we think that that's really the next step, is really to be able to say with almost 100% certainty that someone has been infected or they haven't been infected. And at least I think the clinician can then take it from there and then decide, are they sick or aren't they sick? Do they need antibiotics or they don't need antibiotics, et cetera, et cetera. But I think this is where we're at right now, is that as a clinician, very often you're left in this ambiguous era. There's a lot of ambiguity because you can't, we've become very dependent on testing. And so what I want to emphasize, when you use the current testing out there, nothing is going to give you, at least for early disease, no test is going to give you certainty. The only thing that you're going to have to make your decision on is what your clinical judgment is. And I think that, as far as when a patient comes in this community and has a particular set of illness at a particular time, and it's early, they have had exposure, you do your clinical history, I think early treatment prevents a lot of problems later on, which are even more ambiguous in terms of etiology. But I want to thank George. I think it was a beautiful presentation. I'm going to use your slides now. I'm going to steal those. They're really good. And I appreciate being here. Thank you.